Hello, welcome. Today we're going to talk about aftercare and our whole spectrum of options and which one is the best for you. I'm Troy Faddis, Clinical Director of Legacy Outdoor Ventures.
And I'm Dr. Maddy Liebing, the Clinical Director for Juniper Canyon, and I'm just happy to be here.
So I think one of the hardest things that we all do, choosing to go to primary care, particularly to a wilderness therapy program, is a hard decision. But I've been told over and over again that it's even more difficult making the choice for an aftercare than it was to decide to go to a primary care program. So let's talk a little bit about what type of options there are, why each option is different, and what type of criteria you might want to consider in helping you decide.
One of the things that we wanted to do as a segue from the presentations that we've been doing over the past few weeks is to just refresh and remember, this is a handout that we sent to you guys this week, is the things that we can do to be able to have a heart at peace conversations with our young adult children. And we mentioned, I just sort of expanded what we had and talked about last week is what do we do to do reflective listening, and that you don't have to agree with what they're saying, but they need to be heard. So you're going to seek to understand. And then we talked about last week moving down through the influence pyramid and making sure that we're in a place where we're not in the box. And then keeping in mind that in order to stay out of the box, we need to employ certain ways of helping ourselves stay mindful and grounded and staying in the present moment. We just threw out a few ideas here: breathing, moving, yoga, using bilateral stimulation we mentioned last week, walking, treadmill, cross-country skiing, jogging, horseback riding, anything that moves you bilaterally. And then on the next slide, kind of finishing up some of the things that we've talked about, the EFT cycle, those negative cycles we've been talking about for the last few weeks. But one piece that we haven't really talked about is self-care and lifestyles. There's a book called The Depression Cure that some research that was done at a college over a long period of time of changing your lifestyle in order to be able to eliminate depression, basically, without medication. And it's acknowledged that sometimes people still need medication, but these activities, these 5 or 6 things, will have a tendency to change the way that your whole body chemistry works. Engaging activity, physical exercise, sunlight exposure, social support, getting good sleep, and then good nutrition, including omega-3s. And those are, 5 of those 6 things are, part of a wilderness program. That's one of the reasons why it works so well. But as parents, we can incorporate those things into our lives too, in order to be able to handle all the things that you're going through, especially during the COVID stuff that we're trying to deal with. And then we talked
about— As you're talking about those, Maddy, tell me if I remember right. Didn't he have one that we're not listing here? You talked about doing a specific intervention that's therapeutic about what happens when we get ruminating on a specific thought and how to stop that ruminations.
He talks about rumination. He definitely does in the book. And that's one of the things where we just keep cycling around about negative stuff over and over and over. And it's almost like we magically think, if we think about it enough, that we're going to somehow eliminate the problem. And all it does is just cause a dent in the ground. When you keep walking in a circle, it just increases the impression of that negative cycle and doesn't really get us anywhere. And so he does talk about rumination in that too.
Yeah.
And I think he has that. I think that's in the section where he's actually talking about engaging activity. But I can't remember for sure exactly where it's at, but it's a good point.
Yeah.
Setting boundaries with our children. And then we just talked about addressing charged topics. All of the above are ways to be able to handle these kinds of difficult conversations. But the key is to see our son or daughter as a person and not as a problem, and to be able for us personally to stay out of the box. So this is just kind of a refresher of the work that we've been doing up to this point about how we can be more effective in working with our children and also in our relationships generally. So what we wanted to do as we're rolling into talking about aftercare is, and this is also in the handout that we sent, so you don't have to try to remember all of this, but these are some of the therapy modalities that actually incorporate neuroscience into what they do. You can see wilderness is one of those. Bilateral stimulation, EMDR, brain spotting, all of these CBT, DBT, ACT, IFS, there's all these initials, and EFT, neurofeedback, then a communication. When you're looking for aftercare, these are some of the modalities that you're going to want to make sure that these companies and programs have, because they're the ones that are actually employing the neuroscience that we've been talking about and are going to be the most effective, especially some of them are just essential when it comes to working with trauma.
Yeah. Some of those best practices or evidence-based practices that we know help treat the things that we know our clients need the most help with for this to stick.
So Troy's going to give kind of an overview of the care from the beginning to the end. And one of the things that you're going to notice, and we've talked a little bit about this, is these follow the stages of change and the research that's been done about how typically people change and the steps that they go through. And we've mentioned this before, but we'll mention it again and you can see where it fits into different levels of care.
Mm-hmm. Before clients typically come to us, they do something, and it may not be formal, but a lot of times it is, to stabilize. And that may be a detox. They may need 72 hours, maybe even a couple of weeks to make sure that they're medically safe. That's part of that medical stabilization. Maybe they're coming from a hospitalization because of suicide ideation, or maybe it's drug-induced or like diagnostically induced psychosis. Sometimes they've been arrested and they may be temporarily in jail, and some of those things are going to happen there. But essentially, we want to make sure that we've stabilized the client as much as we can before they're entering primary care, just so that we have the best chance of them staying in the spectrum of care, both at primary and they're set up throughout. Because one of the things that I've experienced, and I'll probably say this a couple of times, is that as we go through these things, I've identified what I believe are the goals of each level of care. And if we move on to a level of care, not having done, if we've missed one of these goals, my experience is people have to come back and do that work. And they may be able to do it wherever they're at in the spectrum. And sometimes they find themselves back in a stabilizing place, in a detox, or they find themselves back in a primary care. And it's usually because they left some of that work undone. And that's why it's important for us to try to not make a revolving door of treatment. We really do want to set everyone up for unavoidable success. And the best way to do that is making sure that they are accomplishing the task.
And I just want to throw out that research has evidenced over and over and over, as well as our own practical experience with the clients that we've worked with, is that the more you can have these gradual step downs with support all the way back into, completely being, in a general outpatient sort of situation, the more success that we have. And the more we try to shortchange these or make it go faster, the more we put our sons and daughters at risk.
Mm-hmm. Yep. So primary care, we are Legacy in Juniper Canyon. We are an example of primary care. And when clients first come, they come for a lot of reasons. Sometimes they really do see that they need help. But sometimes it is parents, a loved one, a spouse, a parole officer or lawyer. Sometimes it's other people that have helped them see the need, or at least have given them the direction to seek out primary care. And so, when clients first get here, we are spending the first couple of weeks, maybe longer, maybe shorter, of just trying to help get a proper evaluation, know what the diagnosis is, and helping our client and their family too be able to see that that issue, that problem, for what it actually is. Not bigger, but not smaller. We want to right size what's really happening and help everyone really face it. And that's that second part, which I think has to happen in primary care, which is the ownership. People typically make a lot more progress in their mind than they're willing to show out on the surface. Maybe it's just a vulnerability issue, it's an autonomy issue, but it takes some time for what's on the outside to match what's being considered on the inside. So not only do they need to see it as a problem and not just other people, but they need to own it as their own and really start making some goals to move forward with finding a solution for them that is going to stick, not just an easy answer. And as I'm sharing these things, I hope that you're thinking about, whether it's for yourself or for a son or a daughter, how well are they seeing it? And also thinking, are we on the same page? Do they see the things that I see? Are they seeing more? And do I need to see some of the things that they're talking about? Do I want them to see some of the things that I'm talking about? How well are they addressing it? And again, some of this may be something that neither of you saw, but you're doing some psychological evaluation, a full battery of evaluations, and looking at a diagnostic formulation and really honestly considering the recommendations that are being put forth in that document. Can we see those things, own those things, and say, yeah, I can see how this is something that if I work on is really going to help me move forward? Or do I block that and I don't really want to address it? I'd rather just sidestep it. And that's part of that moving forward. It's actually making at least a partial commitment. A lot of times we either decide or we slide into our decisions. And the question is, maybe I'm still sliding in there, but we're trying to, within primary care or eventually in intermediate care, we need to make a commitment that I'm ready to do whatever it takes to address these things so that they don't keep coming up in ways of my life that are going to hold me back. And if I have a block to something, I need to evaluate in my therapy and maybe in my relationships or family therapy or relationship therapy why I'm blocking those things.
And one thing that I think is really important in this section too is that the seeing part, the evaluation part. But if the client is struggling with really deep and difficult issues, for example, trauma, or some kind of traumatic experience or experiencing PTSD, or if they've had problems with, we get a lot of adult children of alcoholics where there's been one or both parents and caretakers in the family who have struggled with addiction themselves. Those are deeper problems. And part of what we do here is, first of all, to identify that. That's part of the evaluation, for them to be able to acknowledge, well, this is creating a problem for me, to create metaphor for them to understand how this is affecting the way that they operate generally. And then we can't resolve a trauma in 90 days. And so what we do is we start with what's called resourcing, which is to help them to develop foundational skills that will help them deal with the anxiety and the trauma response, fight, flight, and freeze, and be able to recognize when that's happening and have a place to go with that, develop a safe, calm place that they can that they can go, a container to put painful emotions and somatic responses in, breathing exercises, mindfulness exercises, meditation exercises. So you create a foundation to be able to actually, that you have to have that foundation before you can actually start to work on the trauma itself. So that takes a chunk of time, and you've got some, good resources with the wilderness. But then we can actually start working on the trauma, and you can find out the modalities that are going to be the most responsive to. So, like a lot of us do EMDR, or you might use internal family systems or other kinds of trauma modalities. And if they have a really difficult time with it, then you don't want to waste time trying to make that work or make them fit them into that square peg in a round hole. But you try something else. And so part of what you're doing is finding what's going to work for them going forward to continue to work with that, because the actual work for trauma and some of these really deep issues that they've had or continuing to have are going to take not just 90 days, but months. And a lot of times EMDR and some of these modalities take a couple of years, and they'll be doing just individual therapy eventually for a long period of time. And I think realistically, we have to realize that this is not something that you can say, oh, there it is, done, okay, move on. It just doesn't happen that way. But we can get a lot of the foundational work done in primary care and give them a kind of a taste of success of how does that feel to start to, have some desensitization around that memory, or have some opportunity to have some of those memories begin to, come back together again in a less painful way. And so that's all part of what happens in primary care, with the idea that needs to continue going forward into intermediate and extended care.
Yeah. And I really do believe in these things. I came up with them out of my experience. And I guess like that's one of those things where I sharing this with clients, want them to own the process, because I found that I can't make the process go faster or shorter, and I can't shortcut something from it. It is what it is. And I think that there is it's a catch-22. I think knowing this and being able to truly own it gives some comfort that that they have control over it versus it being done to them. It's like the idea of locus of control. If there's an external locus of control, they feel like it's being done to them. And if there's an internal locus of control, they believe that they have control over the outcomes in their own life. And so the benefit of what I think, because most clients and their families, they're really worried about a length of stay. Well, how long is this going to be? How long can I do this faster? How fast can I do this? And I think that's why like every step builds on the other. How will I stabilize? In fact, I could have put maybe interventionist under stabilize, because how much a client is coming into the program truly already seeing and having accepted the work that they need to do, the faster they do go through the program, as long as that is genuine and remains so. But some of these diagnoses, and this is maybe the thing that they're worried about, is if they really face it, that these diagnoses can create a lot of cognitive distortion, cognitive dissonance. And so a lot of my time, honestly, in primary care, it might be 3 weeks, it might be 7 weeks, is helping them and their family at times get over the cognitive distortions, the cognitive dissonance, to get to a place where they truly understand what needs to be faced and start making a treatment plan for leaving primary care and being set up for success beyond.
And this follows the stages of change. Research done of the stages of change indicate that all of us, regardless of what we're changing, go through some common stages. And the first one is just denial. And that's the pre-interventionist place, where I don't think it's that bad. I can stop anytime I want. You've heard all of those, where it's like, I'm not even thinking about it. I think it's everybody else's problem. It's not my problem. If you just relax, it'd be okay. That's before stabilization, and then into stabilization. But the C part, the part that Troy is talking about, is this beginning to actually realize, well, there is something wrong. and I need to do something about it. In the stages of change, it's called the contemplation stage, and Troy likes to use the word see, which I think is perfect for that. And then in that same section, then you begin to, when you start getting into actually doing ownership and moving forward, then you're starting to do preparation for change, and you might even start doing some action and getting into the change. So some of these overlap a little bit, but depending on how they respond and how they move forward and how much they're willing to take that ownership, depends on how far you can move down the stages of change.
Mm-hmm. So jumping to intermediate care, and intermediate care has been shrinking. I think managed care has shortened it, and I think recovery programs still do a better job at providing this, but a lot of programs now, including us to an extent, we tend to start to blend intermediate care with primary care. But I believe that the task of intermediate care is very different than the task of primary care. So I really want to make sure I make the task of what you need to accomplish clear. And an example of how we blend it is that we have Summit House for the men. And Summit House, primary care is pretty cognitive. It's about that, aha, I get it, I see it, and I'm ready to do something about it. And that can be pretty invigorating to have that moment where you're like, I get it, let's get to work now. Intermediate care is where we really test that resolve. I put practice at the end, but I almost think that that's the biggest part of intermediate care. Well, let's start putting into action then. Let's try it out. I mean, I think you have to explore your options. Well, okay, I want to do it. How? Maybe I want to start doing some more EMDR. Maybe I want to do a Gorski relapse prevention plan. Maybe I want to, explore doing, more family therapy or doing some family sculptures but it's I also need to start doing it. I'm not just written down a Gorski relapse prevention plan. I need to have a chance to actually try it out. It's when we do Summit House, there's a little bit more freedom. They have their own bedroom right now during COVID, but do they keep their bedroom clean? They have a little bit more leeway in the daily schedule. So they have, do we want to play a board game or watch a TV show or a sports event, or they have a lot more ownership over cooking and cleaning the kitchen and what type of food do I want to eat. They don't have full freedom, but there's more options. And I want to see if they're going to choose the options they said they would. If they said, I want a morning routine, I want to wake up at this time and do my morning routine, do they actually do it? Do they have an evening routine, and do they do it? We're in primary care, the staff often are responsible for the schedule. And intermediate care, there's some transfer of ownership to see if they can own the schedule. And if they don't, well, then it tightens up. If they do, they can have more and more opportunities. That's really the role of intermediate care, is to start to practice these things and see if I'm really good to do it. It's where things get exposed, because people say they want to change a lot, but when they have to even start doing the smallest thing, they don't actually follow through. And that's one thing I love about intermediate care at Summit House. And I should say, be clear, we're still primary care. The reason why I don't call it intermediate care at Summit House is because it's not long enough. The time there is short enough that we really haven't had a good litmus test yet. Not enough data. But the idea is get some data, see how we really respond to that, and we may expose that maybe I didn't fully accept things in my primary care task, and I need to go back and do that. Or I find out I am doing these things, I am learning, and I'm ready to move forward.
It's like I train horses, and it's like having a round pen is a very small space, and it's round so that they can't get caught in a corner. They can be safe as they move around, and it's very safe and very contained. But you typically have a round pen inside of a field or inside of a larger space. And what an intermediate care is that you've been working with your horse inside this small contained space. Now you open them up into the field. You open the gate. You're in really in intermediate care. You start opening the gate, and you still might have a halter on them, or you might have a rope, or something like that, so you can reel them back in if they get into trouble. But the idea is what are they going to do with that freedom? Are they going to immediately, go after whatever and not use any of the skills that they've already acquired? If that's the case, then you're going to bring them back in and put them back in the round pit, and work with them more, because that means they need more structure for a longer period of time. And that's what they're doing, is they're gradually opening the gate wider and longer periods of time, and they're getting into the community more. Now, it's hard with the COVID because they have a hard time getting out in the community now, because we're also be sheltering at home and all that kind of stuff. But they're still finding ways to be able to make that work and to be able to get people out into the community to whatever degree their state or their community allow that. But it's modified a little bit now, but that's the idea, is open the gate and see what they do with what they've learned.
Yep. And that moves us to extended care. And extended care programs can look really different. But I really believe that the tasks that you need to accomplish at extended care are all the same. And the intention of extended care is to provide a safer, real-life experience. And so what extended care programs do, some of them are college-focused. And it's not typically having a full caseload, a course load. You're probably not going to start out with 12 or more credits. You might start out with 3 or 6, maybe more, maybe less. But if it's a college-focused extended care, it's about trying to create some normal things that you would be doing, like moving forward with other goals too, but you're still in a scaffolding situation where there's a lot of checks and balances. And some of it may be like about how to stay sober in a college environment. Some of it may be about how to make an academic plan and how to study and how to have a social group and do all those things that you are now integrating with the options that you committed to, the treatment you've committed to, and keeping it intact. But extended care is also where we are going to make mistakes. And I think that's one of the most important things to help us know, am I ready for extended care or am I not? Is that if I think about making mistakes, and they have to be big ones, they can be small ones, but is that something my instinct is to hide? Or is it something that I recognize as a chance to learn? Am I ready to bring those mistakes I've made to my new group, to my peer, to be peer accountable, to be accountable to the program, and be able to work with them to retool, resharpen that saw, and let's figure out what happened and why did it happen and what was the context, and let's move it forward. We're not starting over, but if I'm hiding the mistake, then I might be. If I can't own the mistake, that may be a big red flag. And if I'm not learning from the mistake, it may show some cognitive dissonance that is still happening. And so I think that the being honest is one of the hardest things about choosing this level of care. Because as we can see here, let me get my pointer out. What I've experienced is that almost everyone, including managed care and including us as family members and parents, we all want to go right from primary care, and we want to eliminate intermediate and extended care and jump all the way to outpatient. If everyone's being honest, that's the goal. And they want to go as quickly as possible. It's also, as Maddy said, the research does show this. It's also the greatest setup for failure. When we see a 2/3 relapse rate from a lot of programs, a lot of that has to do with being the wrong level of care and jumping from a higher level of care to a lower level of care, skipping the ones in the middle. So a lot of times we see primary care, it does become a revolving door because we're not doing the task that are required to each one. And so if clients or patients are hearing that, they're like, okay, if I'm not really ready, and they probably see the data too, they say, at least I'll jump to extended care. I'm going to skip intermediate and go straight to extended. And I don't think that like any of these jumps aren't impossible. If we play the what if game, we can what if any success. However, if we're jumping to extended care just because I want the autonomy or just because I want to move forward with other goals besides my substance abuse goals, my anxiety goals, my depressive mood disorder goals. If like other things become more important, then I may misread, like, am I really ready to learn from the mistakes that I'm going to make? And are the mistakes I'm going to make going to be ones I can learn from and not be so critical that it forces me back through the spectrum and come back around?
I was going to say, and this is following the stages of change again. Intermediate care, you start action a little bit in primary care. And then in intermediate care is where it really takes place. And you're doing the preparation for sure action. And then extended care is the action phase. And it starts to move into maintenance, which is the last stage of change. And you can see that outpatient is maintenance. So if you think about it from this idea of the stages of change, if the action is really taking place in intermediate and extended care, and you go from primary care, which is contemplation and a little bit of action, or a little bit of preparation, and some maybe a little tiny bit of action, not a little tiny bit. There's action that happens there. But if you're taking all of that and jumping to maintenance, you haven't had enough practice to actually have that become a part of the way that you operate. And from a trauma standpoint, you've got to have those pieces in between. You're exploring options, you're committing, and you're practicing. But part of what you're practicing is actually healing, treatment. Trauma healing. It takes time. You can't. I always say you can't push a river. You can't make it go faster than it goes. And so you have to give yourself time to heal. And if I've had people who wanted to just jump over and say, well, I can just do outpatient for my trauma, it doesn't work that way, because if you don't have all of the other safety pieces in place, you're not going to be able to work on your trauma, because you've got to be in a safe environment and be able to have those checks and balances to keep you safe while you're doing some of this initial, healing stuff. And so one of the things that I just want to throw out there, Troy, too, and I'm sure you're going to address this, but a lot of the programs, when they leave primary care or leave like Legacy and Juniper Canyon, programs that they go to are typically incorporate intermediate care, extended care, and even outpatient in the same program, so that they can continue with the same therapist and the same basic program, but they have those step downs within that same community, so that they don't have to start over again every time they move to a different level of care. I'm sure you were going to talk about that. Maybe that was
well, then they do, like some programs, they really do, they try to provide the whole spectrum. Mm-hmm. I think some programs recognize that they're really good at specialization, right? They're really good at specializing in the primary or intermediate care. Most programs, they don't try to, like, these are more signposts along the spectrum, and they're not intended to be like, oh, this program's a primary care, or this program's an extended care, or this program, maybe some programs are that way, but some programs, they try to be 2 of them or 3 of them. Some of them try to be all 5.
Yeah.
And I think that that's part of the evaluation, that I hope, taking this information, you start thinking about, what do I need? What does our family need? Where are we really at? And start to like then evaluate how we're going to make this decision. In fact, Maddy, I realized as we just started today that there is another slide that I needed to make. Because one of the things I do with most of my guys as they're making this decision is I ask them to create what I call a heuristics chart, or heuristics decision. He's a mathematician, and it's a little bit like a Consumer Reports. That dates me. I know that everyone uses the internet now. I think Consumer Reports is still a thing, but when Consumer Reports says, all right, tell me about toasters, and they're going to come up with 4 or 5 criteria to evaluate that toaster on, and then they're going to do that with every toaster, and they're going to give you a numerical score between 1 and 5, and then you're going to input the total score, and then after they've gotten the total score, they can have like, this is the best choice. They'll actually reveal the cost. So they actually have a best choice and they'll have a best buy. And so you can look at, was that little bit of improvement worth that big cost difference? And so, that made, I always encourage people as we start having this conversation to be really, again, as honest as they can be. What is the actual criteria that I'm probably going to use to make my decision about an aftercare program? Does it provide the types of therapy that Maddy, you were talking about? What type of therapies do I actually need to keep this going? Is it about other external goals starting to have a place to move on, such as college or job or a 12-step community? Physical exercise, the type of physical exercise, and then like things that maybe matter to us a lot, but maybe don't matter to our actual success. And that could be things like, I wanted to be somewhere really warm. I wanted to be next to the ocean. I wanted to be next to mom and dad or at home. And not that those things are irrelevant, but they may not be actually what is going to help me be successful. And all of these things stick. And so I need to acknowledge, like, if I'm going to choose on those things, then that's what I'm going to choose it on. But are most of my criteria, and I try to keep it to 4 or 5. Don't try to have like a million criteria. But those 4 or 5 things, are they really about me accomplishing the task at the level of care that I'm going to be at?
What I call it, we call it a lot of times is a wants and needs list. So on one side is the things that I really have to have if I'm going to continue making the progress that I'm making here at Juniper Canyon or Legacy. And then what are my wants? And I do the same thing. You can do a mathematical sort of thing. You put values to each one of those. Like there's on a scale of 1 to 10. Would this be a want, a need that has a value of 9, or a need that's maybe a value of 5? And you can, what happens is once you get those put together and you start exploring options, then you can do the same thing with the program. So on the programs, you can put down, what are the pluses and put a value to that. On the other side, what are the minuses of this program? Put a value to that, add it all up, and you end up with an equation and a number that is there, is this going to be more valuable than another one? And you have like 3 different programs you do that with, then you can compare those numbers. And what we're teaching in that process is not just helping them define aftercare, we're teaching them an adult process when you're making an important decision, is to have a criteria to your wants and needs and balancing those, and then making the decision based on what are the pros and cons of each one of these potential decisions. And that can be used for careers, that can be used for college majors. It can be used for colleges, which college that you want to go to, and all of the different adult decisions. And shoot, you can use it for deciding if you want to marry somebody or not. Your list. Do they meet my criteria? But the idea is to teach that adults don't just say, "Oh, I like this. I think I'll go there," or they won't just say, "Well, my friend said it was cool, so I think I'll do that." The adults actually do a logical process of determining what it is that I need and what's going to meet those needs.
I was going to use that example because I think it's super important to admit which of the criteria is actually more important to you.
Right.
Because the one about college, like how often do we sit there and say, does it have the program I might want? Does it have, is the connections? Are the professors? Is it a teaching university? Is it a research university? What type of quality of connections do they have that might help me get a job at the end of it? And actually being able to see that on the front end is pretty hard, because how often do our children make decisions on the college they want to go to on things like, well, all my friends are going to this one. Right. My boyfriend or girlfriend are going to this one. This one's closer to home, or this one's further from home. And how often are those actually the things that the choice is actually made on, and not really the data?
And I think one of the things that, as we move through these different levels of care, when we get to the outpatient care, That's when they really are completely using those skills and generalizing them and maintaining the things, the changes that they've made. Establishing roots and supports is to develop a recovery community, a community of people that you feel comfortable with. And sometimes you have to translate, what am I trying to say, move to a different location to do that. A lot of times what we found is a lot of our clients will, once they've established all of this, might even stay in the same community where they were going through these different things, because they've established friends, they've established a job, they've been going to a school that they like there, and they have a recovery community to help support them going forward. And that's the most effective, is when they can, and if they have to move, then they have to just go through that process again and intentionally establish a community that's going to support them in the things that they need to do to continue their recovery.
And I just would add to outpatient care is, like, we've got to generalize. We're going to be generalizing skills to each one, but generalizing the skills to outpatient care may be the one that's going to take the most intention.
Mm-hmm.
And then knowing that we're really ready,
right,
to do this, and I guess maybe it's both generalizing skills and readiness to establish my roots and own it myself, that I want to highlight, because that's one thing that makes this level of care different from all of the other levels of care. And that is that extended care, immediate care, primary care, all of these, they have a robust checks and balances system. There is an accountability built in with staff and therapists and programming and just a schedule that's often owned by the program. When we get to outpatient care, all of that is owned by the client or the patient themselves. Parents can try to be the monitor. Parents can try to be the pop police. They can try to be the schedule police, the making sure things are going right person. But if that often doesn't work, we quickly fall into old dynamics of pushing and avoiding. And so it's so much better for them to be able to be honest and say, I am ready to own it, and I have proof and data behind it that I can own it, that I have been owning it, and I'm ready to take that last step to owning it completely. And I may ask for help, and I can ask for support from parents and everyone else, but it is mine, and I'm more invested in it than you are. And so we know it's going to stick.
And the hard thing about this is this whole process, this is the hard reality from the brain neuroscience that we've been talking about in the last couple of weeks. This whole process takes about a year. It's just all there is to it. Mm-hmm. 90 days or so in primary care, intermediate care, and to extended care, probably somewhere around 6 to 9 months. And then outpatient care needs to continue for another 3 to 6 months. And the idea is to be able to have enough support and direction and therapy and all of these things to be able to give the brain a chance to completely heal. And at the same time, help our young people grow and mature and develop the things that they need to do to be able to continue to be successful and not go backwards. But one thing it is important to know is that, say they do get to aftercare and they struggle, they go back to extended care for a bit. All of these you can circle back if you need to, and if you get far out too soon, then you circle back to the one before, and getting that help. But it's much better to do that than to do primary care and then jump over to outpatient care and then screw up and then jump back over to primary care and then go back over to if you keep skipping the middle parts, you're going to just keep having more primary care and more failure, and eventually it's going to get to a point where they don't feel like you can be successful.
Yeah. So my encouragement is, look at the task, be honest, see how much cognitive dissonance might be there, start to make, as Maddy said, a needs and wants list, or at least the criteria of how you're going to judge this decision, and start being honest about the evaluation, and then working with therapists, working with your educational consultant to come up with options that fit along the spectrum where you need to be. Thank you all so much for listening, joining, and being here with us. And please subscribe and hit the notification button so that you can stay on top of all of our webinars. Have an awesome afternoon. Be healthy and stay safe.
See ya.